Today I'm going to perform a lower extremity biomechanical exam. In the clinic, I'd compare left and right sides, but for sake of time today, I will only be showing one side. In the clinic, I would also have access to tools such as a goniometer or an inclinometer, but I don't have those here with me today, so I'm going to be talking through what I would do with those. I would also include a gait aspect of the assessment in the clinic, but for sake of time, I left that out of today's video. In the first part of this assessment, I'm going to be looking at leg length. So what I want the patient to do is go ahead and bend their knees and put their feet flat on the mat for me. I'm going to make sure that the heels are nice and lined up, and I'm going to look at the levels of the tibia on either leg, and then I would also examine the femur on either leg and just look to see if there's any discrepancy in length in this position. Next, I'll ask the patient to go ahead and bridge up for me. Good, and back down. And I'm going to straighten the legs out and compare length by looking at either malleoli. He seems to be in line here. So next I'd ask the patient to go ahead and sit up straight for me to perform a long sit test and compare leg length in this position as well. And he seems to be even. Next I'm going to be looking at malleolar torsion. I'm going to make sure that his femur is straight and his patella is pointed up towards the ceiling, and I'm going to create a straight line going through either malleoli with both index fingers. So I'm going to go in on either side, and this is going to create an angle with horizontal. If I had a goniometer, I'd be able to measure this angle and hope that it would be between 20 and 30 degrees, which is considered normal. So I'm going to get pretty low here, try to look straight down the leg and look at the angle, which he seems to be in line within normal to me. Next, I'm going to look at forefoot position in the sagittal plane. I'm going to look for a normal drop off from the forefoot to the rear foot. Normal degrees would be between 12 and 16, and he doesn't seem to have any equinus here. Next, I'm going to be looking at mid-tarsal mobility. So I'm going to be testing two axes here, the oblique and the longitudinal. The oblique axis is responsible for dorsiflexion, plantar flexion, and adduction, abduction, and the longitudinal axis is responsible for inversion and eversion. So they both start the same way by putting the calcaneus into an inverted or everted position and simulating supination and pronation. So I'm going to start off by inverting the calcaneus, and we're going to test the oblique axis by taking that mid-tarsal into plantar flexion and dorsiflexion. Then we're going to evert the calcaneus and do the same motion. You'd expect to see more motion in the pronated position because it creates a more supple foot than in the supinated position, which creates a more rigid foot. Then I'd test the longitudinal axis by inverting the calcaneus and doing inversion and eversion at the midfoot. And then everting the calcaneus and doing the same thing. Same thing here, you'd expect to see more motion in pronation than you would in supination. Next, I'm going to be looking at the position and mobility of the first ray. So what I'm going to do is take the first ray and the lesser four toes and put them into a pincer grasp in my hands, comparing either side. Here, I'm trying to see if they're on the same plane or if the first ray is in dorsiflexion or plantar flexion. He seems to be pretty in line here, so nothing to worry about there. Next, I'm going to be looking at mobility. So I'm going to make sure that the lesser four rays are stationary, and then take the first ray down and in and up and out to test the mobility there, to kind of go in line with the cupping motion of the foot. Next, I'm going to look at hallux position and mobility. So I'm going to be looking here for any excessive hallux valgus. Anything less than 15 degrees is considered normal. I could use a goniometer to measure this by putting it on top of the foot with the axis over that first MTP and then down the center of the toe and down the first met head. He doesn't seem to be in any excessive valgus here, so that's good. And then for mobility, I would test great toe extension passively, since that's really important in gait for the toe off side part of the gait cycle. So I would go ahead and passively extend the great toe, hoping that he would get at least 60 degrees. And it seems like he definitely has that. I could also use the goniometer to measure that here. Then I would look at the lesser digits for any abnormal positioning, if it was hammer, claw, or mallet toe. And then I would also look at the plantar aspect of the foot and look for any abnormal callousing or any type of ulcer or lesion, and note that on the sheet as well. Okay, next I'm going to be assessing subtalar neutral. So what I want to do is find the midpoint of the calcaneus and the midpoint of the lower leg and mark it with a pen. So I'm going to use a window grip to go on either side of the calcaneus and try to find the center, making sure to not use the Achilles tendon as a guide. And mark that with a pen. And then I'm going to do the same thing with the lower leg. And these will be my reference marks for whenever I measure subtalar neutral. Okay, now that I have these reference marks, I'm going to go ahead and attempt to find subtalar neutral. So I'm going to grab the talus with my right hand and move into supination and pronation until I find an equal congruency there on either finger. And once I find that, I can use the references as a guide. So I'm going to compare the rear foot to the lower leg first and note if there's any abnormal varus or valgus, and then compare the rear foot to the forefoot and note if there's any abnormal varus or valgus. He seems pretty okay to me. It seems like he might be in slight valgus in the rear foot. So I would note that on my sheet. And then I can measure subtalar range of motion with a goniometer. I would move the calcaneus into inversion and eversion, so I'm going to go ahead and do that. And then you can line the goniometer up between the malleoli and use the guidelines as reference for your moving and stationary arm, and then eversion and measure it. You would hope to see a 2-to-1 ratio, 20 degrees to 10 degrees between inversion and eversion. Obviously more motion in calcaneal inversion than in eversion. Then I would measure ankle range of motion. So while they're in a knee extended position, I'd ask them to go ahead and dorsiflex, and I would measure with the goniometer lined up here, and then I would get them to plantar flex and measure that there. I would also do it in a knee flex position and re-measure ankle dorsiflexion. You'd hope to see more motion in dorsiflexion with the knee flexed. Okay, next I'm going to be looking at neutral tibial stance in standing. So what I'm going to get the patient to do is I'm going to assist them to get back into subtalar neutral by giving them some cues such as roll the foot in and out or move your arch up and down for me. Stop. Okay, so once I find that subtalar neutral, I'm going to ask them to hold that position for me, and I would get an inclinometer and I would measure the lower leg reference mark the degrees, as well as the calcaneal reference mark and mark the degrees. These should be kind of similar since they're in that subtalar neutral, and normal would be about 0 to 4 degrees of varus. Once I have those starting positions marked, I'll go ahead and tell the patient that they can relax their foot. Good. And I would re-measure at the calcaneal reference mark and get a new number for the excursion, the weight-bearing excursion. And normal would be about 4 to 6 degrees. While they're standing, I can also look at their forefoot position, so I'd ask them to take a few steps, like marching steps for me. Okay, and I would look to see how many toes I can see on either side. So too many toes sign would be greater than 2 toes. Normal is about 2 and 2.5 toes that you can see from the back. Go ahead and turn towards me. I can also look at the weight-bearing hallux dorsiflexion in standing as well. So I would just passively extend the great toe, and I can measure that with a goniometer, and I would be looking for about 10 to 12 degrees there. In the seated position, I'm going to be looking at arch height by doing the navicular drop test. One thing to note is to make sure that their ankle is right under their knee and they're in really good alignment here, and to go ahead and mark the navicular with a cross using a pen. I'm going to go ahead and use a note card to mark the starting position of where the navicular starts. Then I'm going to ask the patient to go ahead and stand up without taking a step. Good. And I'm going to re-measure that position. And then I can use a tape measure or a goniometer to measure the excursion there, and normal would be between 6 to 8 millimeters. And that would conclude the lower extremity biomechanical evaluation. Thanks for watching.